Hello, everyone. I am Bevey Miner. It is 10 o'clock on the West Coast, which is where I'm sitting. So without further ado, I'm going to go ahead and start diving into this solution session. So today we're going to be talking about improving patient care outcomes by using real-time ADT event notifications or real-time ADT alerts, as some of you may have heard that term used, because it's top front of mind right now because of the new CMS 21st Century's Cures Act final rule. So let me dive right into my slides, and if any of you are having either trouble hearing me or you can't see my slides or advance my slides, please feel free to chat, and I will try and adjust the screen or figure out from a technical perspective what I might need to do to change that. So we are going to spend the next 30 minutes talking about improving patient outcomes, improving health outcomes by looking at notifying the care team. Seems pretty logical, but it has been challenging in healthcare technology to be able to connect all of the providers that are treating a patient and really enhance that continuity of care as patients move from one care setting to the next care setting. So I'm going to talk a little bit about the CMS rule. I'm going to dive somewhat into what that rule means, but I'm not going to spend a lot of time on the regulatory part of what hospitals have to do or what conditions of participation really mean. So if you have further questions, you want me to elaborate on that a little further, I can do that as we move forward in the presentation or towards the end when I do our questions and answer period. So just a little bit of background about me so you can understand why I'm passionate about this, why I believe we need to finally get to the stage of interoperability and data sharing and communications. Is that I've been in this business for about 20 years. I started in health information exchanges when we were really trying to figure out what kind of standards, what sort of methods could we use to be able to communicate amongst the entire care team. I've been instrumental in leading a lot of strategy, product management, business development, marketing, communications. I've worked with a lot of emerging health IT markets, a lot of patient engagement tools, moved forward on what we're doing on smartphones. I got experience working at both NextGen, Allscripts, Practice Fusion, and a number of other really exciting Silicon Valley startups as well. So I've been following this pretty closely. I'm one of these interesting people that likes reading proposed rule and final rule and trying to figure out how it matches to the different organizations that I work in so that we can provide the kind of valuable tools that you need to be successful in the highly regulated framework that we work in. So let's look at what real-time event notifications really are. And I'm going to focus on, you're getting a sneak peek at something that J2 Global is going to be launching later on this month. It's called Consensus Signal, but what it really does is it connects the hospitals through an automatic notification to the downstream care team, and it provides that ability for everyone touching the patient throughout that transitions of care, where usually the most errors happen, as well as building that communication chain through the continuity of care. So let's look at how big the problem really is today. You've heard so many different vendors and hospitals alike talk about the readmission issues. And what can we do to prevent patients from returning to an acute incident, to returning to the hospital? And the problem is still big. We've been talking about this, as I said, since I've been in the industry for about 20 years. Automated notifications can reduce that readmission by up to about 18%. And that's just making sure that when a patient is discharged from the hospital, that they have immediate follow-up care, so that there is nothing that is preventing the continued focus on the patient's health outcomes, and there is no lapse of care. So it makes sense that automatic notifications to the downstream provider team would be able to reduce readmissions, and studies have shown it can do that to almost nearly 20%. But what's also interesting is that 1/3 of primary care docs are never notified that their patient was admitted to the hospital. We're all patients, so or maybe we're a caregiver for a loved one that's elderly. And, frequently you'll hear the primary care doc, say, well, what brings you in today, Mrs. Smith? Well, doc, I was in the hospital last week. And the primary care doc has no visibility to what happened, what was the diagnosis, what was the treatment. They don't have the discharge plan. And it's very, very concerning when you're missing that step, because many of the discharge plans are telling the patients to comply, follow up with your primary care doc within the next 7 days. But studies have also indicated that a 10-fold increase in the risk of those hospital readmissions happen with patients who are not seen by their physician within at least 30 days of that discharge. And most discharge plans say, go see your primary care doc within 7 days, or it may be a specialist depending upon the type of treatment you received when you were in the hospital. And this just leads to a really big lack of care coordination, which can lead to poor health outcomes, as I've mentioned before. So let me talk just a little bit about the CMS new rule. And the CMS rule, and maybe you've even heard about the conditions of participation. This is a term that CMS uses when they want to define who has to comply to a particular rule. Who's that target market that we're talking to? The acronym is COP, this particular rule for the admissions, discharge, and transfer alerting is focused on hospital systems. The rule will take effect on May 1st of 2021. The initial deadline for this was September. Due to COVID, most of the 21st Century's Cures Act's final rule were pushed back into 2021 or even 2022. And the conditions of participation require, and they mandate that notifications are sent for Medicare and Medicaid participating hospitals, which includes psychiatric hospitals. So this is quite interesting, because when we've looked at behavioral health care in the past, it's always been a carve-out. It's a care setting that has not really been integrated into communications for continuity of care, but it causes major, major issues if the entire care team doesn't understand what's happening with the patient with their behavioral health treatment. It can lead to contraindications of drugs, and you are not holistically treating that patient, because many medical conditions can be manifested by a behavioral health condition. So you have to get to the root of really what is the cause for the patient's problems. And without sharing that behavioral health incident or behavioral health diagnoses and treatments and plans for psychiatry, much of the rest of the medical treatment team is at a loss of what to do. It also includes critical access hospitals. This is going to be particularly challenging for critical access hospitals, because they don't have a lot of technology to be able to satisfy an electronic notification. They're running on very, very short margins. Under COVID, you probably read the news that many of them are threatened to have to close their doors. In fact, 120 critical access hospitals were pleading to CMS for some bailout money because they were not going to be able to keep their doors open beyond 30 days. Much of this is what is also plaguing the entire industry under COVID, and that is that elective procedures were not being done in hospital systems. The requirement is to send an electronic patient event notification of either an admission, they were admitted to the hospital, that they were discharged, or they were transferred to another care setting. And these electronic patient notifications, they've proven to be a tool for improving transitions of care between these care settings already. Many of these tools have existed. In fact, Consensus Signal has been working with a lot of hospital systems and other stakeholders since 2017. So this requirement has already been in place in many hospital systems, mostly the larger IDNs, but now it is sweeping across the country for all Medicare hospitals or Medicaid hospitals. So let me talk just for a few minutes about what Consensus Signal does. And this really isn't meant to just be this solution. It's any really good, reliable, automatic. And I say automatic because when it has to be done manually and the admitting procedure has to say, okay, now I have to send messages out that a patient has been admitted. Or if a patient is discharged and that has to be done manually. This is where we miss a lot of the care team communication. So being able to do this and do it automatically, and I'll talk a little bit about how that's done, at least in this example, can route that ADT message or the ADT alert to provide everything from gaps in care, messages about care transitions, alerts that will go directly into the EHR of the patient's provider or a care manager are the most effective alerts because it makes it really easy in the workflow to be able to have an actionable data set that goes into that downstream provider when it's communicated through an EHR. Now, it doesn't have to be. CMS isn't saying that the ADT alert has to go directly into an EHR. Doesn't say it has to go directly into a certified EHR, which CMS usually pushes and promotes. But the most effective is some sort of it can be a portal or it can be a secure email box, but it just has to be easy. It has to be done in a way that makes that workflow the data and the workflow easy to access for a particular provider. So let me talk for a few minutes. This is not meant to be a technical slide. It's not meant to dive deep into any CIOs or those on the phone that are having to set up infrastructure within your hospitals. And again, it's meant to be sort of a representative way that you can do an ADT alert. This happens to be the Consensus Signal workflow. Right now, what's happening at a level of the Direct Trust, which is the governing body that manages all direct messaging HISPs, there's conversation going on with Direct Trust right now about how to standardize, there's a standards body looking at ways that you can use direct messaging to be able to communicate the mandated ADT alert notification. So watch for or look for the standards with which the Direct Trust standards body will start to recommend. If you yourself are a HISP or you already provide direct messaging or you have a HISP within your hospital systems or your EHR, and the HISP is really the backbone behind direct messaging, you'll probably hear a little bit more about these standards. But likely that the standards will follow some sort of a process like what I have up here on the screen, because direct messaging is one of the key recommendations that CMS put in place in terms of how to send the ADT notifications. You can access through any EHR browser or mobile device or app. With this particular example through Consensus Signal. You can have advanced patient and provider attributions and matching. And what's really important about that is that you might be asking the question, well, how does the hospital know what providers they're supposed to be communicating to? EHRs today have an additional provider team that is attached to that patient record. If that's not within the EHR, many hospital systems have a patient roster and a provider directory. And it can match. It can do that important attribution and matching. In order to do this automatically, as you can possibly imagine, you need to know who is the provider that we have to be reaching out to. And if they have a direct message address, then it's pretty easy to send an ADT notification to that provider using a direct message, a direct message address. It can be done in a rapid deployment. This does not require a lot of technology integration to do the ADT notification. You can do it with an HL7 FHIR-based standard message. You can do, like I said, direct messaging. And the real key with direct messaging is to do it with structured data, to do it in the format of a CCDA, because a CCDA can be consumed by the EHR, as well as that structured data can be much more readable. So you can look at concerning lab results, you can look at a diagnosis that might be concerning. You also might be able to understand what medications were given to a patient upon discharge. And so the CCDA format is much better than an unstructured document for communicating this workflow. And notifications can be triggered for multiple events. It can be triggered for a concerning lab result that may have come back, or it might be a trigger for just a transfer. So a patient may be sitting in an ICU and they're transferred down to a tertiary bed or to a step-down bed. So these can be triggered for multiple events on an ongoing basis. And that's actually a better way to route these ADT messages instead of having to, again, have the manual intervention that is consciously thinking about who do I need to send these messages to. And I think the other piece that's important is, customizing preferences. So whatever solution you choose, you want to be able to turn up or turn down your alerts. We've heard in the industry, the term alert fatigue, and it's very real. It can anesthetize an entire, provider population by the constant pinging that they're getting, or everything seems to be alarming. We've got sensors that patients are wearing today, and any concerning things that can happen, a pattern of high, glucose measures, or a CHF patient that has a Bluetooth-enabled scale that, has gained 5 pounds in one day. All of those alerts are starting to hit the EHR because these tools have the cloud capability to have the messages go into an EHR. So we've heard from providers over and over again, let me customize how I want to get these alerts. Let me be able to determine within my workflow what is going to be best for me to be able to have those actionable items be attended to, and instead of just having them come so frequently that it's almost like you're crying out fire when it's not really that important. So let me walk through this workflow a little bit. You see that you've got the IDNs on the left-hand side of this chart, and what's important about the workflow for this particular example that I'm using here is that this is the basics of what you need to do. There's other alert notifications that focus more on health plans for gaps in care. And so you may say things like a member roster that would also be a part of a workflow like this. But this is for the most part, the workflow that we need to focus on for the COPs, for the hospital systems. So you've got the integrated delivery network, so the hospital's EHRs, and that hospital EHR is going to go through an analytics engine for the ADT notification. And what that will do is it matches up through what's called an EMPI, and I'm going to dummy this down a little bit for those that are not really steeped in interoperability technology. In this example, we're showing that particular IDN has an HIE, a Health Information Exchange, And today, health information exchanges are where you're going to find a lot of the community communication is already happening. The hospital will be feeding into a community HIE. Providers, individual providers will be connected bidirectionally into an HIE. You may even find that you'll have just individual EHRs connected to an HIE as well as health plans connected to an HIE. The EMPI is where you're going to have what's called a master patient index. So again, I apologize for those of you that may already know this, but I want to make sure it's relevant for any level of person that's listening into this presentation. So you'll have this ability to now match patients. This is one of the biggest challenges we've had in healthcare interoperability today is the disparate databases and the disparate systems that patients' content will sit in. And you may be an admission number in the hospital, and you're going to be a lab number for a lab test. You'll be a member number to your health plan, and we don't have one continuity of an identifier. So this MPI technology will allow us to find patients using the HIE platform. Once it goes into the HIE platform, then it can go through the consensus signal backbone, where a subscriber and enrollment, all the rosters are managed within that. And that's where you'd have your automatic alert triggers happening. The configurations will be done within the consensus signal platform, the matching services, the rules engines for, how many alerts do I want? Do I want to have, every ADT alert sent to me? Do I want to only have discharges, or do I need to understand when a patient was transferred from one bed to the next bed? That's where all of the configurations happen underneath the settings within consensus signal. And then again, consensus signal can connect up to these different rosters, patient registries, even an opioid registry, an immunization registry, whatever kind of a communication workflow or protocol needs to be communicated through that HIE. So, we think of this as just ADT alerts, admissions, discharge, and transfers, but a lot of what you might want to generally call alerting is done in other types of settings or technologies. We have a national directory for opioids. We have a national alerting backbone. So whenever a patient is prescribed an opioid, it has to be registered at a state level. And there is a national backbone for understanding that as well to track opioid prescriptions. So that's another use for this alerting type of technology, as well as any kind of, like I said, concerning lab messages as well. Now you have to figure out, all right, I've got this. I can either go directly from the hospital EHR, I can go from the IDN's EHRs. It's gone through some sort of an HIE or matching algorithm, like an EMPI. We've gone through the consensus signal configuration and alerting technology. And how do you want to now send this message? And you can see, as an example, sending it through a direct message is going to be a very common practice to do that as a secure direct message, as long as you have the direct message address of the provider. You can also send those notifications via HL7, text, a report, or via, like I said, a direct message. Then on the recipient's end, you've got a number of different stakeholders. I mentioned payers. Gaps in care are so important for health plans today, because when you think about the kind of data that health plans get on what's happening with their patients, it's claims data. And that claims data is latent. It doesn't happen until the provider has filed a claim. And that doesn't allow health plans to really be part of I don't want to say an oversight, but an extension of that care team, to use the health plan's care managers to be able to navigate the sickest of our populations, the comorbid patients, the ones that have high levels of acuity, that are costing the system the most amount of money. Health plans need that gap in care information. They need to have it as soon as they possibly can, and they are a very big stakeholder that can have tremendous impact to health outcomes as they look at navigating and helping the patient navigate through their network and understand how they can get the kind of treatment that they really need to have the best health outcomes. It can be integrated into a user with an EHR, and I've mentioned that that's probably the easiest workflow that you can think about. It can also be used for a user without an EHR. So if you have a document management dashboard that is a HIPAA secure dashboard where all of your lab results come in, your discharges come in, maybe advanced directives might come in through there. J2 Global happens to have a product like that is a connector product underneath our consensus product portfolio. But any of those portals will suffice to be able to get an ADT message. And then mobile, I think, is really important. We've heard from a number of providers that say, boy, I'd like to get a message, even if it's a direct message, on my phone that says, a patient has just been admitted to the hospital. In a specialty world, you may even think about a cardiologist that just needs to know if one of his patients has been admitted to the hospital, so they can make sure that they're on alert to be able to get down to the hospital, particularly if they need to put a catheter in or do a balloon procedure. The time wasted can cause additional damage. So let me move on because I know I wanted to give about 15 minutes for questions. So who benefits from all this? And I've mentioned some of these stakeholders before, but let's talk specifically about what their benefit is. Ultimately, the patient is going to be the best beneficiary of alerting their entire care team. But drilling down into each one of these different stakeholders, you can start to understand why this is so important. So hospitals, we talked about reduction of readmission penalties. They need to meet a CMS rule. And when CMS puts these rules in place, sometimes that's the biggest benefit. If I can meet that rule, then I don't end up with the penalties. This penalty could be huge. CMS did not determine exactly what the remediation is if you don't comply. There's pages and pages about how you have to prove that you've tried to be able to send a message to the receiving entity. But CMS also knows that the hospitals can't control if the skilled nursing facility can receive an electronic message or if a particular provider group can. So they are not responsible, but they have to prove that they've tried to send that message. If the hospitals do not comply, there's conversation about losing your Medicare status, and that could be big. If hospitals don't have that Medicare status and being able to treat the Medicare fee-for-service beneficiaries, many of those hospitals cannot financially stay afloat. So this is going to have a harsh penalty to it. You also can learn when your patients are admitted to or discharged from out-of-network providers. So a patient may be at a center of excellence getting treatment at your facility, but they really get most of their treatments done at a community hospital that may be 50 miles or 100 miles away. If the provider is still attached to that patient record, these ADT messages will go to that hospital to be able to keep an eye on the patient as they move from network providers to out-of-network providers or even within a geographical area. And that helps hospitals a lot with leakage and understanding where their patient population is going after they have an episodic instance at a particular hospital. Post-acute care organizations, they really benefit a lot from this because they need to understand if you're a skilled nursing facility, was a patient discharged? Well, we want that patient. It helps with referrals. It improves home care coordination. It improves going in and look at the sickest of the populations, the ones that are our highest utilizers. They're in skilled nursing, assisted living, rehab centers, back in the hospital, seeing their primary care docs, seeing their specialists. Many of them have 5 to 6 different physicians that they have to see on an ongoing basis. And then all of these post-acute care providers in the different care settings will now be able to have clear understanding about what's happening to the patient. It increases that continuity of care and ultimately really improves care coordination. Integrated health delivery care systems, if they have a large campus where patients are coming and going and they're utilizing a lot of the services, there may just be redundant treatment. There may be redundant labs that are done. You can look at medication reconciliation as being a huge, big issue when patients are put on duplicate therapies because you don't understand what kind of treatments were being done to a particular patient. So integrated delivery systems, really can look at this as reducing their costs and reducing those emergency room visits as well, even if the patient wasn't readmitted to the hospital. I've talked a little bit about commercial health plans. They are really on an ongoing basis, constantly trying to manage their high-risk members, close those gaps in care, make sure that those members are seeing the follow-up care team as they need to, that they're getting the kind of tests that they have to get. And some of them might just be, complying with key tests that a particular patient at an elderly stage might need, a colonoscopy, a mammogram, etc. And if the providers are not communicating and we're not doing these ADT messages to the commercial health plans, they really aren't aware of what's happening to their patients at the time that encounter is happening, which is extremely important for them to be able to manage that care as well. And then it also helps with, the EMR into the workflows to meet the quality and cost measurements and the thresholds for value-based care. So all of this does have a focus on value-based care. And many of the commercial health plans have reimbursement programs that are still focusing on lowering costs, increasing the quality of health outcomes, looking at the patients, the patient engagement, patient satisfaction, which are the part of the triple aim. And then Medicaid, Medicaid is particularly challenged because you're looking at a patient population that doesn't even really have a care team that's keeping an eye on them on an ongoing basis. They have such periodic, episodic interactions with the healthcare system or a provider, and they are extremely high risk because it's really hard to keep an eye on the care that those patients are receiving. But with these ADT notifications, you can see that a federally qualified health center, an FQHC for instance, or a community center will understand that one of their patients has now entered the hospital. And when I say their patients, if they just have a single record of an encounter from a patient that's entered an FQHC, they can now do that proactive outreach back to that patient if they've been in the hospital to say, come back in, we need to follow up with you, we need to see you on an ongoing basis. FQHCs are not under the same value-based care model that a lot of the provider organizations are, so they make their financial return by having an encounter with a particular patient. So they're very incentivized to getting a patient back into a care setting for follow-up and making sure that those patients stay out of the hospital. And done well, you can really reduce the cost of care in this underserved market, but we have to notify the care team. So Medicaid has a really big advantage here. So let me just stop there. I've got about 10 minutes for questions. I do want to mention again that the example of the product I showed, Consensus Signal, you got a sneak peek at it because we are going to be launching that officially on October 19th. I would encourage you to find out from your EHR companies what plans they have to help support this, and if they don't, or you're not really seeing that it's the kind of workflow that you want, you'll be able to find ADT alert notifications coming from a number of different reliable vendors and sources that have been doing it. I would also recommend that you think about asking whoever you choose to help you satisfy this final rule. How long have they been doing it? Do they have any kind of use cases or case studies? Because this is not new. You'll see a lot of new players enter this market because when CMS puts a broad sweeping rule like this in place, a lot of the vendors will want to be there for their providers to be able to help satisfy this rule. But as you go out and search for partners to help you, meet the requirements, you may want to think about asking some of the same questions of the features I've just presented here today. So I have about 10 minutes or so to engage some questions. So let me go ahead, and if you want to type your questions in the chat, I think that's the best way to do it. I think there's a way you can raise your hand, but I apologize if I can't virtually see that. So any questions that you might want to send in my direction? And I'll stop for a minute and let you collect your thoughts. I've got a couple here that I just got in. So one of the questions is CMS likely to push the deadline back for this due to COVID? This is I'll give you my opinion on that. We haven't heard that CMS is going to push this deadline back. And I think what's important about that is that under COVID, it has been very apparent that if we had had ADT notifications in place, if we had had some of the information blocking rules in place, we would have done a much better job of being able to manage patients and their treatment under COVID. So I doubt if CMS will push this particular requirement back. I would be moving, fast and forward to satisfy this requirement so that you're ready to go by May 1st. I think it's just really important that you don't wait to see if that's going to happen. So let me look at a couple of these other questions. Are ambulatory providers held up to the same data sharing rules that the hospitals have? So I think what might be meant by this question, and if I don't answer it correctly, please chat me again, but I think what you're meaning is, if I'm a provider in a clinic, do I have to have any kind of alert sent to, if I happen to be, let's say, a cardiologist, do I have to send an alert to a primary care doc that I'm treating a patient? And no, CMS is not saying that these ADT, automatic ADT alert notifications have to be done by providers. Providers are pretty much held up to MACRA and MIPS requirements coming from CMS. Providers have a lot of the measures that are in MIPS today that can be satisfied by communication with the entire care team for continuity of care, for compliance and gaps in care. But this specific rule is not a requirement from the CMS. So I think, following up on an alert that you've had, seeing that patient within 7 days after they've left the hospital will help meet many of your MIPS requirements as well. Let me see what other questions I've got here. Another one that just came in is we heard about direct messaging, and we heard about HL7 messages, but what about any other means that you can send messages back and forth? Well, CMS has clearly said this has to be electronic. So that means that sending a paper fax is not going to work. You can send a cloud fax, which is electronic, a digital cloud fax will satisfy the requirement because CMS didn't carve it out. So if that's the only means that you can used to communicate, then by all means, then, I mean, don't not communicate, but don't send a paper fax, go to a digital cloud fax. Then there's a number of companies. In fact, J2 has eFax Corporate, which also satisfies a digital cloud fax capability. What about a patient or a caregiver? Can they get notified as well? And that's really an interesting and important point that you brought up. Is that many patients that are comorbid and expensive and utilize the system. They've got caregivers that are underutilized. Caregivers are the free resource that can help treat those patients if they know what's going on. If you've been a caregiver for an elderly loved one, particularly if you are not geographically located, it would be nice to know if mom or dad entered the hospital. CMS isn't specifically saying you have to notify whoever that family caregiver has to be. But if it's attached to the patient's record, and many times it is that here's the caregiver, then Consensus Signal can send a message to a PHR, a personal health record, or actually send an alert notification to any kind of an application that a caregiver may be using to help take care of a particular loved one, or communicate to whoever's listed and is allowed to be able to see what's happening with that particular patient. How big are the readmission penalties for hospitals, and will this really be a big issue since, I think what's meant by this question, rather than have me read the whole thing, is that, some hospitals are trying to do what they can to manage the readmission penalties, and some of them are just writing off the readmission penalties. But it's big. It's not to be underestimated. Over $500 million worth of penalties were delivered last year to, I believe that number's right, to hospitals that received a readmission penalty, and I think that constitutes over 80% of Medicare hospitals that because they fall under a Medicare hospital. And they're held up against these readmission penalties. Over 80%, I think the number's like 83%, receive readmission penalties. This will be huge to reduce readmission penalties. So it's one of the follow-up care after the patient leaves the hospital. I can't stress it enough. We'll keep that patient out of the hospital and keep them from being readmitted. And we're doing a lot of treatment at home today. Patients are being, the skilled nursing facilities are being disintermediated even. And it's like, can we really bypass the SNF and just send the treatment for the patient home? And that does a couple things. It means they're getting sent home with a higher acuity level, which means that they can come back into the hospital. They can be readmitted because they're not as stable as we might think. But home health is growing for that reason. So these ADT notifications going to home health will really have a huge impact on the ability to treat the patient at home. And telehealth is also being used within a hospital setting. So rather than have you come back into emergency, we'll work on what we might need to do for wound care. And if you have a surgical site infection, if you can do it in a telehealth visit and just prescribe electronically prescribe the right kind of antibiotics, you don't need to have an expensive emergency room visit. So start to look at ways that telehealth will be used in a post-acute care setting instead of the constant, high utilizers of our emergency room setting. I think I have time for maybe one more question. This one I think I answered, but I'll answer it a little more specifically because maybe I didn't do a good job the first time. How can we as providers handle alert fatigue? Because you're going to get a lot of them now that they have. You're going to get a lot of alerts now that they have to. Providers have to send the ADT alerts to you. Well, within at least Consensus Signal, we have a configuration dashboard that will allow you to turn up or turn down the alerts. And I would always recommend that you ask if you have the capability to do those customized settings. So I think I'm just about out of time. So I'm sorry if I didn't get to all of the questions, but you can feel free to go out to that website that I've listed on this last slide, and fill out a form for us. We'll notify you when we're getting ready to launch this product. This is a specific product to meet the ADT notification CMS rules, but we've been doing this along with our partner for quite a while. And then you're also welcome to email me through the HealthIMPACT email portal that you can do, and I'll be glad to answer additional questions. So thanks again for your time. I hope I was able to educate you a little bit and make you feel like you've got a solution that can help solve this problem. That deadline's coming up pretty quickly. Thanks again.